research is. And then I'm going to ask him a few questions, and then we'll have plenty of time for everybody else to ask questions. He's not giving a talk per se. This is such an interesting time to have an infectious disease expert with us that I thought it would be best to just let everybody ask all the questions that they have. So, so Samion, tell us about yourself and what your area of expertise is and your research.
Yeah, sure. Well, thanks for having me. It's fun to have a chance to talk with you all and answer questions. So I'm an infectious disease and addiction specialist in Boston. I take care of patients in an HIV clinic and then also in a drop-in site for people who use drugs. So a lot of people who have hepatitis C and other injection drug-related infections. And then I also see patients in the hospital who have other kinds of infectious diseases. And then my area of research is really focused on figuring out how to improve access to addiction treatment for people with substance use disorders who find themselves in the hospital.
Thank you, Samion. So one question that's been on our minds a lot recently, especially with the new CDC guidance that just came out in the last couple of days, is you know, when can we start having services? For right now, we're just looking for outdoors with singing, mask wearing, social distancing. Given the new CDC guidelines, what do you think of that idea? Is it safe to have services outside where there will be singing?
Yeah, so I think you know there's a lot of variables that go into how to think about risk. So there's what the kind of population prevalence is of COVID. There's how many people are vaccinated. There's what the kind of ventilation is, right? Or if it's outside, it's obviously less risk. What the kind of whether there's gonna be singing or heavy breathing like exercise, whether people are gonna be masked, and then also the time in one location. So all of these things go into factoring in the risk. So I think the short answer is that of all the studies of looking at outbreaks, and there's very little transmission in outside, and so the CDC guidelines updated in response to that evidence, and so my sense is that having an outside gathering where people are socially distanced wearing masks, even if they're singing, is probably quite safe, especially if the community has a high rate of vaccination.
Mm-hmm. And what if the requirement? What if we institute a requirement that in order to attend you have to be vaccinated?
Yeah, I mean that's an interesting question. I think obviously the more people that are vaccinated, the lower the risk of any kind of social gathering. You saw the CDC guidelines, which they right now limit it to kind of still smaller gatherings that of people who can get together without masks. But I think we're going to see lifting of the limits. In Massachusetts, they just announced that they're expanding the number of people who can get together at any one time. So the more people that are vaccinated, obviously the safer it is, because vaccination both has been shown now to both prevent hospitalization and death, but also to decrease the risk of transmission among people who actually do have COVID. So that makes it safer. I think creating requirements is another discussion, and an interesting one. I think at least hospitals thus far have not required people to get vaccinated, and I think part of that is related to the fact that the vaccine is an emergency use authorization vaccine. We're required to get other kinds of vaccinations, but it hasn't been a requirement. But there's there's pretty high vaccination, at least among clinicians.
Mm-hmm. So we have a pretty high vaccination rate among our congregants. We did a monkey survey, and most people said they were either vaccinated or going to get vaccinated. I think we only had one person say that they could not get vaccinated for whatever reason. So it sounds like we're in pretty good shape. What about holding inside services? What's your prediction for when that will be safe? And I have to say, we're not at all going by what the governor says, because our congregation, most of us are not. I mean, I'm sure there are some people that are eating in restaurants, but we're being more conservative given the age of our population. What are your thoughts on indoor services?
Yeah. So again, I think some of these things depend on what the overall prevalence looks like as time moves on. How densely populated the space is seems to have some relationship to risk of infection. So I think I looked at the Connecticut guidelines right now, and I think they're similar to the Massachusetts guidelines, that it's supposed to be 10 square feet per person for indoor religious gatherings. So I think we're not too far off from being able to get together in that way, but I think we're not quite there yet. I think everyone is waiting to see what happens with the variants in particular, and the risk gets bigger the more people are together in one space. So, but I think we're not so far off.
That's good to hear. And speaking of the variants, do you think that is there any indication yet that the vaccines that we've all received are not protective against the variants, or are they still holding up so far?
Thus far, it seems like they're effective against the variants. There is one variant that's circulating that's a little bit less effective, but it's not very common right now. And so the B117 variant is the one that's really making up the dominant proportion of infections right now. I think it's like close to 60 or 70% in Massachusetts now. And that, is a change from back in January. So, the current vaccines seem to be very effective against that variant. So I think we'll have to wait and see, but I think most people are feeling pretty optimistic about it.
That's great. I know one area of concern for you is equal access to the vaccine, and I think there are a lot of us in our congregation that are concerned about that. Given that, at least in Connecticut, it seems to be they're not able to convince enough people to get the shots, that there seems to be an excess of vaccine right now. What are your thoughts on how to incentivize people to take those vaccines that currently aren't being used, and do you think there's still a disparity among economic groups with respect to the vaccine?
Yeah, I mean, there's definitely we definitely are seeing a disparity, which isn't so surprising. Some of that is probably related to the way that the age breakdowns in terms of who had access to vaccines earlier and who lives longer, and structural racism and the relationship between economics and living a long time. But I think I saw some data in New York City where it's like in the Upper West Side, it's close to 60 or 70% of people who have been vaccinated, and in Queens, it's closer to 30% of people who have been vaccinated. And I think there's a lot of reasons for that, and a lot of people are studying how to improve vaccination rates. So there's a lot of there's certainly a legacy of mistrust of the healthcare system, especially among people of color. There are people who feel disconnected from the healthcare system. There's until recently, the access was not was not equal. I think now we're starting to see more efforts to expand access to people. I think there needs to be efforts to get people to bring the vaccine to communities where people are not getting the vaccine. I work at Boston Medical Center, which is a safety net hospital in Boston, and the hospital knows that the community that the hospital serves is not going to necessarily come to the hospital to get the vaccine, and so they've set up vaccination sites in various communities. They've brought out people who have been vaccinated from the communities to be ambassadors. So I think it'll really take a multi-pronged approach. But certainly we're seeing the way that the vaccination unfolded. Certainly people who are older are at higher risk for having worse outcomes from COVID. But there may be people who are able to isolate during, despite not being vaccinated, you're only at risk for worse outcomes if you get the infection. So if you're able to isolate, then you're not going to get it. And most of my patients have had COVID. They got it because they were having to work, and they were having to work outside of their homes. And so, you see that. And so even if the risk of having bad outcomes is lower, because people can't isolate, we were still seeing a lot of that. So I think there's a lot of work to do to build that trust and to actually make sure people who need the vaccine can get it. But there's certainly a lot of people who have hesitations about it. I spent a lot of time talking to people about the vaccine today, including today. So.
Well, I'm going to open it up for questions now. I'm going to switch this to gallery view so that we can see. So who has a question for Samion? Barbara. Yeah, there you go.
So if the CDC is saying that we can, I am specifically thinking about a wedding I'm invited to in September with 150 people, indoor and outdoor possibilities. So when the CDC says you can get together outdoors without a mask or indoors with a mask or any combination of those with a small group, like in your backyard, how is it different if you get together with a large group and like example, they're letting people in Yankee Stadium, maybe not right next to each other. So where is the line drawn that it's okay to mix with some people, but not maybe hundreds of people, or is it okay to mix with hundreds?
Yeah, I think early on in the pandemic, we were seeing these charts basically, which had to do with what the population prevalence was, and and what the size of the gathering was, and you could see the probability that there might be somebody who was positive at any given gathering. So I mean, it's that concept, right? That the bigger group you have, the greater the chance that there's somebody there who is infectious. So the likelihood of transmission is much lower outside. The likelihood of transmission is much lower if most people are vaccinated. So I think you're seeing the CDC try to balance these and crunch these numbers and figure out what's safe. And so they've said that getting together in a small gathering outside is safe, but the risk is greater when there's more people, and then obviously the risk is even greater when it's inside. So I think that's what we're seeing, and in a community where everybody's vaccinated by September, we might see that the CDC says that's okay. I'm not sure.
So if you went to a gathering where everyone was vaccinated and you still wore a mask in the indoor part, then you could take the mask off in the outdoor part if everyone who attends is vaccinated. I don't know about the crew though, people who were serving the food, I don't know about if that's included in that.
Yeah, exactly. So there's, and I think some of the limits on travel and the limits on gatherings and whatnot have to do with that. That it's not just the people who are traveling, but it's all of the staff and all the other movement that happens, and the risk, the risk associated with that. So. So I'm grappling with the same thing. I was also invited to a wedding in California in October, and they haven't required that people are vaccinated, but I suspect most people will be. And as someone who's vaccinated, I would feel comfortable going to that wedding outside. I probably wouldn't at this point feel comfortable doing it inside though.
Mm.
Thank you. Who else has a question for Samion? Ira, and then go ahead.
Yes, Samion, I've been recommending both the Pfizer and Moderna vaccine over Johnson & Johnson because of efficacy, but I've never come across a study that compared them over the same geographic area and same time frame. Have you ever seen such a study?
No, we don't. At this point, I don't think we don't have that data. And I think we're going to see more other vaccines also coming on becoming approved and made available, especially in other parts of the world. The Johnson & Johnson vaccine is an adenovirus vector, so it's a more kind of traditional vaccine technology, and the best vaccine is, as we've been saying to folks, is the one that you can get. And now at our hospital, when you sign up to get a vaccine, you don't have a choice. You don't have a choice about which vaccine you actually get. You just show up and whatever they have because of the shortages. The benefit of the Johnson & Johnson vaccine is that it's one dose. And so, there's some proportion of people who don't end up getting the second dose. And, on a population level, the efficacy is really, quite impressive. When you think about what, Tony Fauci was saying, that it would be successful if the vaccine was 60% effective. And so, I think all three of these vaccines are incredibly effective. There was this pause for the Johnson & Johnson vaccine, and they ultimately ended up, recommending that people continue to give the vaccine. But an arterial thrombosis of this sort is a pretty devastating outcome, even though it's extremely uncommon. And so, I think it'd be pretty reasonable for women under the age of 50 to think about getting, given that there's an alternative safe vaccine, to think about the alternative vaccines. And then the Moderna and the Pfizer vaccine are the newer technology, the mRNA vaccines, which is really, almost magical, but, they've been working on the technology for a long time. And are incredibly effective and, seem to be quite safe. So.
What I also didn't realize until I started reading a lot is the influenza vaccine only has about a 60% efficiency every year.
Yes.
That's poor.
Yeah. Some years it's actually less than that.
Right.
But yeah, absolutely. And so it's about as good as we could have hoped for, I think, in terms of having these vaccines, and as safe as they are, as quickly as we did.
Thank you. There was a question. I'm going to take everyone who hasn't had a question first, Barbara. Sorry. Reva, did you and your husband have a question? I saw a hand up in your blog.
Oh, yes. Thank you. Thank you, Samion, for doing this. I think most of us recall 16 months or so ago, we saw these images out of China where bulldozers were constructing hospitals just as quickly as possible. And 2 or 3 months later, that all came here. And we're hearing horrible stories right now out of India.
Yeah.
So tell me, please, why this is different.
why it's different in India than
Why it won't come here this time?
why it won't come back here. You know, at that point, you know, 16 months ago, the virus the population in the U.S. was unexposed to the virus essentially, or you know, it was circulating at low levels. And now the virus has circulated through a large proportion of our population, and increasingly people are being vaccinated. And so the concept of herd immunity is not so much that there aren't new infections, but that there's not new outbreaks. And so, you know, over time, basically, there's this concept called in infectious disease epidemiology called an R0, which is basically anyone who's infected, how many people do they transmit that infection to? And so, you know, that's partially the characteristics of the virus and partially the characteristics of our behaviors. And you know, if you can reduce the R0 to less than 1, then you know, the outbreak doesn't grow, and that's when we've reached herd immunity. So you know, we think now that basically the virus has an R0 of about 2, maybe 2.5, taking, you know, given the existing social distancing that we're doing. So I think essentially, I mean, to get back to your original question, we're in a much different position than we were 16 months ago, in terms of, you know, our preparedness and the vaccination rates and whatnot. Obviously, what's going on in China, I mean, in India is a humanitarian disaster. You know, people not having enough oxygen, you know, the lack of access to vaccines, basic, you know, it's really quite devastating. But I think the one concern is that when there's this is really a global, you know, global pandemics are you know, infectious diseases are global events, and you know, the more infections that there are, the more opportunities there are for the virus to mutate, and for new variants to emerge. So that's the big concern about the fact that there's, you know, in addition to the equity concern and justice concerns, when there's, you know, the rest of the globe is not going to be vaccinated for, you know, years, because of the way that the vaccines are being distributed and the technologies being, you know, being handled. That's, I think, certainly a big concern.
Thank you. I think Rabbi Kadeko had a question. Is that right, Rabbi? And then Nancy, I'll get you after that. We can't hear you, Rabbi.
Now you can hear me.
Yeah.
Right? Good.
Yeah.
Samion, thank you for joining us this evening. And I'm sure when you first went into this field, you weren't expecting to be where you are today in this reality. And kudos on the hospital you're working at, since I used to visit it. But now I have 3 different questions. All are going to affect our congregation differently. I'll give you all 3. You answer what you want to answer. Okay. 1, with regard to the singing, right now, for example, when I teach at Schechter, I wear a face shield as well as a mask. When we are moving on to services, and you said, well, you know, depending on where you are, how you are, 12 feet, whatever, 10 feet singing, you know, here's the realities. I know that the cantor who does the who will be at the high holidays again this year, and I have the same question with regard to, do we need to have shields, those big plastic plexiglass things in front of us as we sing, because we're the ones who are singing, even if we wear face masks, and face masks really aren't the greatest thing to wear when you're singing. I do it right now when I'm doing funerals or, you know, with the kids. But if we're going to move into this kind of process here at Bethel, where we're going to open ourselves up either outside, where the wind's going to blow whatever's coming out of my mouth or the cantor's mouth, or we move inside, are there any unique precautions that we need to take? Question 2, and this will affect more of the congregation than just those who attend services. When people go away, like you're going to be going to this, maybe be going to this wedding, the question of hotel rooms and areas that we all need to take care of if we end up having to go into hotels, as to what we really need to do beyond what the hotel is doing, right? And I think that's a very important question to relate to as well. I'll stop with those two questions for now, and I'll let you answer those. And if afterwards, if there's time for the third question, I'll ask. But right now, I know the third question is really like people are going to start making their travel vacations already for next year. Some of our people go to Florida, some go to the Caribbean. Questions about places unlike Florida, but the Caribbean and stuff like that, cruises and stuff like that.
So I wrote them all down here, Samion. The first one was about precautions, special precautions for services inside.
Yeah, so I think we're seeing these plexiglass, plexiglass kind of things in front of at restaurants, and certainly at at doctors' offices for front desk people, and they're in between. Where my daughter has lunch at school, there's a plexiglass barrier between her and the person she's sitting with at her table. So I don't know that they're all that well studied, especially in indoor settings where the virus is aerosolized and transmitting through the air. That said, it probably can't hurt. That we certainly see a fair amount of pandemic theater, but if you're going to be the one singing and having a plexiglass, might prevent droplets from going elsewhere. It doesn't seem unreasonable to me. The face shields, are really more about protecting the person wearing the face shield, because people who basically the droplets can get into your eyes, and especially early on in the pandemic when we were taking care of people who were COVID positive and we didn't have access to N95s, we were wearing just surgical masks and face shields. So that wasn't the ideal scenario, but that was what it was at the beginning. So I'm not sure if that answers.
And then the second one was precautions to take when you're going in a hotel. Any additional precautions?
Yeah, I mean, I think right, the folks in your community and this community are going to be mostly vaccinated. So I think staying in a hotel room, while traveling in an individual hotel room is pretty low risk. I guess there's a theoretical risk about what the air circulation is, and you could ask that to the hotel about how they're filtering the air, or if they have independent circulations and whatnot. But I think we're really moving towards, like, if you're vaccinated, all these things are going to be increasingly low risk, especially on a kind of individual level where there's not large gatherings.
And then the third one was on cruises. Would you take a cruise?
I wouldn't take a cruise right now. Okay. But things as more people are vaccinated and it's clear that the variants are going to be effective towards the vaccines, I think we might be that industry might recover at some point. But I think at this point we're not there.
So I think Nancy Brand was next, and I'm writing down names as you raise your hand. So.
Yes, my question. I was speaking to a friend in Montreal yesterday, and she said, "Oh, you're so much further along than we are here. It's awful." So I said, "Well, have you had your vaccines yet?" And she said, "Yes, I had my first one in the beginning of March, but I'm not scheduled for my second one until June 27th, which is like almost 4 months." So I kept my mouth quiet, but I'm just curious, will she have any benefit from that second shot beyond just the first shot when you get X%? Okay.
Yeah, it's a good question. I actually, I just heard a presentation by Dr. Kizzy Corbett, who was one of the scientists at the NIH who developed a lot of the basic technology and did a lot of the, hold some of the patents for the Moderna vaccine. And one of the things that she pointed out is that a single shot is about 60% or 65% effective, but that's it's more that some people are fully protected at that point, and some people don't actually have the immune system. It's not necessarily that each individual is 65% protected. It's on a population level, people are 65% protected. And there was a big debate earlier on in the, when the vaccines were just coming out about what to do with the shortages and how to vaccinate the most people. And there were a couple of pretty prominent people, the chief of medicine at UCSF and Ashish Jha, who's now the dean of the School of Public Health at Brown, but previously was in Boston. They both were arguing that we should, on a population level, we should really be vaccinating as many people as we can, and not save those doses for the second vaccine. And that's what Canada decided to do. And the people seem to think that it probably would have saved lives if we had vaccinated more people. But that wasn't exactly what was studied in the clinical trial, and so the decision was made here to follow what was done in the clinical trial. There is some thought that people may actually have a more robust immune response if they get the vaccine a little later than a month, as well. So I think it's a little bit of an open, we don't totally know. We don't totally know the effects, but it was a big discussion at the time.
Thank you, Samion. I think Sandy Greenhouse was next, and then Richie. We'll get Sandy. Go ahead.
Hi. We actually had separate questions, if that's okay. I just wanted to backtrack to the cruise subject quickly. Of course, we, like everyone else, are anxious to get back to traveling. And we saw an advertisement for some cruises that are starting up in a few months where there's a vaccination requirement for both the crew and the passengers. Is that something that you would consider an acceptable risk, or is there too much of a risk of people falsifying or counterfeiting vaccine cards, which I've heard about already too?
That's a good question. I obviously if everybody's vaccinated, right, the risk is much lower, and even if there's somebody who's positive, the likelihood of there being an outbreak on the cruise ship is much lower because it's less transmissible, and then even if it is transmitted, then people are not going to get sick. We've definitely seen breakthrough infections of people who have tested positive. Most people have had mild symptoms, but my sense would be I would wait until the CDC says that it's okay to have that kind of gathering, and the CDC is pretty conservative around this, and I would probably go with what they say.
Thank you.
Yeah.
Hi, Samion. It's great to see you, and thank you for doing this. My question is, with your HIV population, of course, they have immune deficiency, and immune deficiency usually or can mean that a lot of people who are vaccinated do not have effective vaccines. Are you doing spike protein antibody studies, and is that even worthwhile to do? And what are your thoughts in regard to immune? Because a lot of elderly people are immune deficient for other reasons as well.
Yeah, that's a great question. No, those studies are definitely ongoing, and in the original in the kind of initial clinical trials, people with HIV were not excluded from the clinical trials, which was among the HIV advocates was a real victory, because the drug companies want to have they were initially wanting to exclude people with HIV, but the populations were small enough that they couldn't actually do good studies to a good projection about whether it was less effective or more effective in people with HIV from the clinical trials. There's definitely ongoing studies to figure out kind of whether the immune response will be different. And I think we're seeing in our more immunocompromised patients with cancer, kind of liquid cancers and other cancers that are, people who are getting chemotherapy, that even if they're vaccinated, that they're the folks who are more likely to have, have complications.
So I think Richie was next, Richie Simonson.
Thanks, Kathleen. Sim, this is very interesting. I just want to ask you, let's say a person has had their vaccines and they say, okay, that's it, I'm good, no more masks, no more distancing. Could you describe the possible risks to that person?
If the person has been vaccinated?
Yes, but they're no longer taking precautions.
So, they're in the like, for instance, in the studies in Israel, there were some people who were vaccinated who died of COVID, but not very many. So if you stop taking any precautions, the risk of infection goes up some. Not it kind of depends on what those behaviors are like, right? And what the other person's comorbidities are. But essentially, the vaccine, the vaccine is probably more effective than masks, and so it kind of depends on what the exposures are.
Thanks.
Okay, who else has a question? If I'm Bev.
Hi, Sim.
Hi, how are you?
I'm good. Good to see you. Okay, I have two questions. When you say, for example, 65% protected, does that mean protected from going to the hospital on a ventilator? What exactly does that mean?
Yeah, so the in the clinical trials, when they looked at how effective the Moderna or the Pfizer vaccines were, the outcome that they looked at was people who were symptomatic with disease, so presented to, and got a test, and they looked at people who were hospitalized. And in the clinical trials, nobody was hospitalized who even received the vaccines. Those are, when you look at a bigger population of people, some people are going to get hospitalized. But so when we say it's 95% effective, we mean it's 95% effective against from preventing symptomatic infection, not necessarily hospitalization or death. It's even more effective in preventing hospitalization or death.
Okay, and my other question is, and I actually read about this in the Israeli Times, why would vaccinated people be more susceptible to the variant than unvaccinated people?
Can you tell me a little bit more about what you read?
I read it last week, actually. But I did read that people that were vaccinated were more susceptible. It was breakthrough. It was a breakthrough.
It's interesting. I haven't heard that. I'm not sure why someone who's vaccinated would be more susceptible to the variants. Thus far, it seems like the vaccine is is extremely effective against the circulating variants. And then the people who have breakthrough infections, even after they've received the vaccine, tend to be more mild infections.
Thank you. And I think Barbara had another question. Go ahead, Barbara.
Yeah, my question is, when the boosters start, is a booster another, like your third vaccine, or is it a lower dose, like a little booster, or is it like having one of the vaccines again?
It's a good question. I'm not sure we know yet what it's gonna look like, because we don't actually know how long the immunity lasts from these vaccines. I think some of it probably depends on what happens with the variants. I think a lot of people seem to think that we'll likely have some sort of booster vaccine, and it will probably likely be another dose of one of these vaccines, but not necessarily a smaller dose. And I haven't heard that. But I don't think it's been don't think it's very clear yet what's going to be the right approach.
And the second part of the question is, if people start getting, you know, I met someone today who had a hard time with her second dose, and she said, "Oh, I just wouldn't even want to get a booster." So if that happened and people were having like vaccine fear or whatever, and a year from now we need boosters and aren't getting them, are we back to square one?
So I guess it depends. I think it's not going to be back to square one because people are going to still have some protection, even if it's not complete protection, as like kind of the immunity wanes over time. You know, the recommendations for the boosters when or if it comes, you know, I think the urgency around that will probably have to do with what the variants look like and how effective the vaccines are. But you know, I think we're gonna have. It's really too early to tell.
Okay, thank you.
Myrna, next Myrna, and then Seema, do you have a question too? You can go after Myrna.
No, I don't. Thank you, Samion,
Oh.
for doing this. I had read that if hospitalizations start going up, that will be the criteria then to give booster shots. Is that something that you're familiar with?
Yeah, you know, I think there's a number of different markers that we use to kind of measure disease activity, and certainly hospitalizations is one, right? It's a later manifestation than the actual number of infections, and so hopefully by then we'll have a better surveillance system that will include, you know, sequencing of the various variants and whatnot. And so I'm hopeful we'll not have to rely on such crude measures like the number of people who are hospitalized, although, you know, that has an important, you know, especially early on in the pandemic, people were talking about hospitalizations because that has to do with the capacity of the healthcare system. And, you know, that people were talking about flattening the curve to kind of preserve the capacity of the healthcare system. So that will certainly be one of many things that are monitored.
Thank you.
So who else has a question? Sandy again?
Samion, you know, I'm often called upon for an advisory role as far as services. And one of the questions is, I know that indoors there's an issue with singing because of the extra distance you have to keep, but have you seen any articles or studies on outdoor singing as far as what's required there, especially now that we're able to unmask, quote unquote? So have you seen any of those studies? I have not.
I haven't seen anything specifically about singing. They did do some studies at the protests where people were chanting, and there didn't seem to be any, you know, higher rates of infection among people who went to. One of these they did in Boston actually. They had everybody who early on when testing was more difficult to come by, anybody who went to any of the protests was offered a COVID test. And the rate of positivity, you know, several days after the protests, was not any higher than the rest of the community. You know, there may be some, you know, selection there in terms of who decided to actually go and get the test, but I think it seems like there's very little transmission outside.
And Artie, did you have a question? You got on mute.
Yeah, maybe about a week ago, there was a New York Times article, and they said that originally when the outbreak started, they would have predicted that there would be tremendous spread in Africa and Southeast Asia, in cities that had poor sanitation, people very crowded together, high population density, and lesser outbreaks throughout the United States and Europe. And they said they still don't have an explanation for that. Anyway, what are your thoughts on that?
It's a good question. You know, I mean, obviously we're seeing seeing this, the outbreak in India right now,
Yes.
which is, thousands of deaths a day and, hundreds of thousands of infections, it sounds like. So it's really, the capacity of the healthcare system and the capacity of the testing apparatus, the ability for people to socially distance, all of that seems to make a big difference. I think one, I don't know. I mean, the public health systems in some of these other countries, are more developed, right? Our healthcare system is really focused on, management of acute issues, and less on, public infrastructure, public, messaging. And then I think, in some places there was really rigid requirements around, around quarantining. If you go to Hong Kong, we got some friends who had a death in the family, and they traveled to Hong Kong early in the pandemic, and they had to pay to be in a hotel for 14 days. They weren't allowed out of the hotel for 14 days. And then even after that, the public health department checked on them every day to ask whether they had any symptoms. And there's a degree of investment in the infrastructure, around public health that's a little bit different. So I think it's an unrelenting virus, though, right? We think that things are better, and then we let up, and then it comes back. So.
Thank you. George, do you have a question? You'll have to unmute.
Would you comment on the current best treatments for mild and moderate cases?
Yeah. So, the monoclonal antibody treatments for people who have not been not hospitalized have been shown to reduce mortality and reduce subsequent hospitalization. The challenge with those treatments really is they need to be delivered to people quite quickly after they've become positive, and then they need to be delivered intravenously, and so they can be very hard to deliver to a population, and there's not that much of them, and so they're also, I mean, the effect is not huge, so that's I think the the best evidence for for people who are not sick enough to be in the hospital. If you're sick enough to be in the hospital, we're treating people with remdesivir, and then people who are sick enough to be in the hospital and also needing oxygen are getting steroids. And then there's some other treatments as well that in some subpopulations seem to make a difference, that kind of dampen the immune response. So they don't seem to make as much of a difference among people who already are so sick that they need to be intubated, but if they're kind of before they're getting sick, that may make a difference.
Thank you. Other questions? Ira, do you have another one?
Yes. I've heard of an MIT study that sort of said in poorly ventilated indoor areas, it didn't make much of a difference if you distance 60 feet or 6 feet. Could you tell me more about what was in that study?
I haven't actually read that study. My parents did text me that study, but I haven't actually read the original study. I think it goes back. It's not so surprising, right? It kind of goes back to the variables, like how long are you there, what's the ventilation like, and the risk is related to those various variables. So if there's a lot of people in a small space with not much ventilation, then distance may matter less. And we saw that even early on when there were the studies of outbreaks in restaurants and things, where people were looking at the airflow, in certain locations of where people were sitting in restaurants and getting infected. So without having read the study, that's kind of how I would think of it, but I'll take a look at the study.
I guess I also heard that initially they thought COVID spread from large droplets, and now it's known that it spreads through aerosolized air. So maybe the aerosolized air travels a lot further.
Yeah, and it hangs around a little bit more. Yeah.
But thank you.
Yeah, sure.
Other questions? Does anybody have another question? Deb, go ahead.
I found the article on the news on my phone. The researchers found the prevalence of B1351 among patients who received 2 doses of the vaccine was about 8 times higher than those who were unvaccinated. So I'm a little concerned about that.
Yeah, I mean, I'd have to take a look at the study. The immediate thing that comes to my mind is that it may be that people who are vaccinated are behaving differently than people who are not vaccinated, right? And so they might be more likely to have an asymptomatic infection because they've stopped taking precautions, whereas the people who are not vaccinated might still be taking precautions. So I without knowing the study, it'd be hard to say. I think one other thing just about the immunocompromised patients and who does how people do with that in terms of the immune response. So the vaccine is being recommended for the vast majority of people, even if people have some immune response, unless immunosuppression, unless it's like very, very severe immunosuppression. So just wanted to add that.
Thank you.
That's a good explanation. Anybody else have a question? I'm going to ask another one if no one else has a question. What would you say to people that still slavishly disinfect their groceries and packages?
That the recommendation to do that came really early on in the pandemic, when there was not that much that was known in terms of how it was transmitted. And I think now we know a lot more, and that it probably the risk of infection from touching groceries is extremely low. I don't do it. I told my parents they shouldn't do it.
Yeah, and I don't think anyone's ever been shown to have contracted the disease in that manner.
Yeah, exactly.
Anybody else have a question? Is that Isla? Or yeah, that's Isla. Go ahead.
There are so many different types of COVID tests. Is there one type that you would recommend over another?
You mean in terms of diagnosing whether somebody has a COVID infection?
Yes.
Yeah. So I think the main types of tests, the tests that people are mostly using right now are PCR-based tests, where basically, they take a sample and then they try to look for the genetic material. And early on, there was most of the testing was like a deeper sample, and then the testing kind of moved more towards anterior nares testing, which is less uncomfortable. When they tried to test my daughter with the higher up test, she swatted them away, but now they're totally fine doing the lower nose tests. So I think they seem to they work pretty similarly between those two, that the anterior tests do perform pretty well. People who are symptomatic, where you have a high suspicion that they might have COVID, we're still using the deeper sample. But when people are asymptomatic, we're using the anterior nares testing. And then there have been some other technologies to try to perform other testing techniques, and a lot of that has to do with basically with ease and speed and cost to be able to expand the testing, because the PCR technology is expensive and laborious. So actually, I'm not sure what they're doing in Connecticut, but in Massachusetts, they're now doing pooled testing in schools, for instance. So they combine the samples of everybody in a classroom and then run it as one test. And then if that test is positive, then they call people back and then test them individually as a way to reduce the number of tests that they need to perform because of the cost and time.
I know some of the quick tests have very high error rates.
Yeah, definitely.
Yeah, our daughter had a
I
select
think,
test.
I think Gabe had a question.
I think I have a question. We hear anecdotally about some people seem to recover from COVID just fine, and others seem to have lingering and maybe lasting effects. Is there anything in the research that suggests what the differentiators are?
I think we don't really know yet. The people who get very sick with COVID, who are intubated in the ICU and have serious pulmonary issues, we're definitely seeing some people have symptoms that last for a longer time, and those symptoms can linger. I think the people who have more mild cases and the so-called kind of long haul COVID type stuff that's in the media a lot, I think we don't really know, and those studies are really hard to do because because of basically recall bias and the way people perceive their symptoms after they've had COVID. It may not, if you're comparing people to comparing other hospitalized people or other people who have had the flu or some other serious semi-serious infection, they may also have those same kinds of symptoms. So I am a little wary of some of those studies, but I think more they'll figure out more soon, and there does seem to be something there.
Thank you. I think Myrna had another question. Go ahead.
Just quickly, thank you. Is it true that people who have been vaccinated can be carriers if they have it in their nose or throat, asymptomatic people, but carry it through their nose and throat? Can they give that to someone who's not been vaccinated?
Yeah. So that's when I say that the vaccine prevents transmission by about 70%, that's what I'm referring to. So people who have been vaccinated can still get test positive for COVID, even if they could be asymptomatic or minimally symptomatic. And it seems that people who are asymptomatic are less infectious than people who are more symptomatic. And so it's possible, but it's much less likely to transmit than people who have not been vaccinated. 70% or so from the real world studies there. Unfortunately, they didn't actually look at that in the clinical trials.
So I also had another question. Early on there was some indication that your blood type would make a difference in terms of how susceptible or how severe COVID would manifest itself? Does the research back that up, that blood type matters?
That's a really good question. I don't know the answer to that one. I'll have to look that one up. I'll get back to you.
Thank you. Who else has a question? Barbara, go ahead.
I heard what you just said, the answer to the previous question. I thought that there might be a problem if you are vaccinated, like if you have a strep test and then you take an antibiotic, then your next test will be negative, even if it's positive, because you're covered by the antibiotic. So is it like that with COVID? Like if you have your both vaccines and then you do have an asymptomatic case, and let's say you have a bad cold and you go and get tested, can you even have a positive test after you have the vaccines?
Yeah, you can have a positive test after you have the vaccine.
So it would be legitimate. It would be correct. Okay.
Yeah, exactly. And it, so it's, I mean, it's a bit tricky because, right, there's people who, you know, probably with a lot of viruses, right, people can have, you know, we've never tested, like, for instance, for flu as much as we've tested for COVID. So, you know, the people who test positive when they're asymptomatic, you know, if you can have you can essentially not have the disease, but have the virus there. And if you've been vaccinated, you're less likely, we're learning, less likely to have the virus there at all. You're less likely to transmit it, and then you're even more less likely to get sick from it.
Okay, thank you.
So this has been absolutely fascinating, Jimmy, and we really appreciate your attending. And I see people are dropping off to go to Minion. Is there anybody else that that has a question before we? Thanks, Samion.
I have one.
Go ahead.
Samion,
Go ahead.
since we have an elderly community, there's more chances of people going to visit into the hospitals and into nursing homes of their loved ones. And the question is related to the concerns for our congregants who go in to visit, as to precautions, perhaps when they leave the hospitals or the nursing homes for their loved ones. We have one congregant who can't see their loved one for 14 days right now because they don't have COVID, neither does their loved one. But where they are is requiring them to wait 14 days before they can go in to visit. Is there anything that we as a more elderly community need to be concerned about when people do go in and when to visit?
Yeah, it's a good question. And I think we're seeing relaxation of these you know, these quarantine guidelines for people who have been vaccinated. So the CDC no longer recommends quarantining when you cross state lines. And I think, you know, we're seeing, I think we're going to see some of the same things. So I think the most important thing to do is to make sure that people are vaccinated, and then if they're going to visit in these indoor spaces, that they should wear masks in indoor spaces and follow those guidelines. You know, if they're going to be seeing somebody who is actually known to be COVID positive, you know, that we're going to start to see more of that now too. That in those circumstances, it might make sense to take some extra precautions, because, you know, before, people who were positive, the hospitals were really restricting visitation. And I think, you know, that's had a really negative impact on the care that people are receiving and people's experiences when they're sick. So I think we're going to see relaxation of those guidelines. We already have seen some of the relaxation of those guidelines. And so in those circumstances, people maybe should take some extra precaution. But, you know, the guidelines now say if you have an exposure and you've been vaccinated, you still don't need to quarantine. So, you know, the confidence in the vaccine is quite high.
Good.
Well,
Thank you.
Oh, we have one more question. Go ahead, Phyllis.
Oh, thanks. I know your expertise is in the adult population, but have you heard anything, or what are you hearing about when the vaccine might be available for the pediatric population? And have you heard anything about, I'm sure they're studying whether or not breastfeeding moms who are immunized, if they're providing any protection to their infants that they're nursing.
Yeah, those studies are definitely ongoing. I don't know about what's known about the transmission in breast milk. I should ask Davida, my wife, is a pediatrician. I'll ask her and get back to you. There's definitely studies ongoing in pediatrics. So there's a clinical trial for the Pfizer vaccine. And actually, our hospital is one of the sites for it. For I think it's as young as 2. And so that, you know, that information, we're not so far off from having more information about how these vaccines will function in younger people.
Thank you.
Anybody else? Boy, this was really a treat, Samion. We so appreciate your coming and taking time. I know you have a young family and are busy in your practice, so we really do appreciate you making time to talk to us. It was wonderful, and people asked great questions. Thank you all for asking such great questions. And
I'm happy to be here. Thank you for inviting me.
Thank you.